It's an honor for me to moderate session 2 of AW Week 2023. It's the 6th year we're doing this interventional course. And we're this year on the road with masters from USA to Asia. And we're going to be talking about endoscopic tissue resection. And boy, do we have a treat for you. We have an absolutely amazing panel of women speakers who are at the very top of our profession. And we're going to ask them everything you ever wanted to know about endoscopic tissue resection. To start with, I thought that we should go around and introduce ourselves. I will start, and my name is Sonia Riker. I am a director of endoscopy at Harvard-UCLA and a co-founder of Association of Women in Endoscopy. And now I'll call on my partners in crime to introduce themselves. Mary Lee, Phoenix.
Hello.
Mary Lee.
Welcome. I'm Mary Lee Krinsky. I'm a clinical professor of medicine at the University of California, San Diego School of Medicine. I'm an interventional endoscopy there, part of a team of 6. And I'm a co-founder of the Association of Women Endoscopists. And welcome, everyone.
Same for me. I'm Phoenix Nguyen. I'm in Southern California at Newport Beach. I'm the medical director for therapeutic endoscopy at Hoag Hospital and also co-founder of AWE. And thank you, everyone, for being here today.
Our pleasure.
Sawani.
Hi, I'm Sawani Ngamrangkong, one of the therapeutic endoscopists at Hopkins.
Maria Jose.
Good morning, everyone. I'm Maria Jose Rojas. I'm an interventional endoscopist at Parkview Health and Parkview Cancer Institute at Fort Wayne, Indiana. And it's a pleasure to be today with all of you guys.
Uzma.
Hi, I'm Uzma Siddiqui. I'm a professor of medicine at University of Chicago, and I'm director of our therapeutic endoscopy unit called the Center for Endoscopic Research and Therapeutics, and vice president and co-founder of Women in Endoscopy. It's an honor to be here with you guys.
Thank you. Yapur?
Yeah, nice to meet you all. I'm Oiporn Kausombat Vachana. I'm from Thailand, Siriraj Hospital, Mahidol University. This is my first time to join this program. Very pleasure.
Thank you so much. Wonderful to have you here. And last but not least, I want to introduce Laurel, who is going to be an advanced interventional endoscopy fellow with Mary Lee, who's been helping us with this course over the past year. She is who we are working for to show that this is doable to our younger generation. So with that, without further ado, we'll start. We want to make it very interactive. So please jump into questions, but we will start with Sawani. Sawani, when I'm thinking about ESD, I always see it as this kind of dilemma. On one side, we all understand that this is good. This is really good. There is this data from Australian group showing that if for rectal lesion, we use selective approach and choose the right lesions, our curative resections rate are better. Everything is better. On the other side, this DDW, we have the study from Spain, from all the centers in Spain, showing that we overstage T1 lesions all the time. So we know we should be doing it. But then on the other side, there is this learning curve of 120, 175 cases. I think the last study I'll review, the person who was looking at it did not reach mastery. I think for 8 years of study, it's like almost make you cry, right? And you actually gave a talk at DDW. I've been trying to get to listen to it, but it's not on demand. That about, I paraphrase, how to create a case for implementation and growth of new technology in your hospital, and particularly ESD. So that is my question to you. With all this conflicting pluses or minuses. How do we do that? How do we bring ESD to our centers?
Yeah, thank you for the questions. And there are other ESD masters in the panel, so please join and share your thought. So in terms of building the business or the program, that talk was about how do we convince the hospital to invest in this technology, because it's quite expensive. Like thinking about the slot time that you're going to be taking to do this procedure instead of doing ERCP or colonoscopy and reimbursement. So the couple of things that I emphasize is that first, if you work in the tertiary care centers, particularly if you have cancer centers, it's very important to have this service, because oftentimes people will just refer patient to consider whether there's an option for endoscopic resection, ESD, or not. So you bring in a lot of referral, just for that. And may actually, it depends on the number, what study you look at. For example, esophageal cancer, if they come, they refer for an ESD. Most of them are not candidate for ESD, but after you assess the patient, then this patient will be referred for consideration of surgery, chemotherapy, radiation. So that's a downstream revenue that not just because of the procedure alone, but because of the referral. Two is, it's very important for your hospital to have this service. If you consider your hospital as a referral center, there are a number of cases that EMR cannot take care of these cases, like failed EMR or unclear staging. So it's to have the complete service at your hospital. So it's complement the other service in your hospital. So in terms of the expense, so we have to show the hospital that giving all this in the downstream revenue and bring in all the referral in the local area or regional area, it will be worthwhile to have this service. Also, the reputation of the hospital, the ranking of the hospital. This is also another thing that the leadership will need to consider. So that's in terms of how do we convince them, because we have to ask them to buy a lot of supplies, devices, train the nurses, a technician to help you do the procedure and support your training. So in terms of training, we would like to hear other people what they think too. I think it's take a long time to reach mastery, but to start, like you can start by like you can start doing on the patient. Doesn't mean you have to wait until 100, 200 cases. But once we have adequate training, that we know the basic, and like your mentor feel that you can perform safe procedure, I think you can start the easy case that still already selected, like antral lesion or rectal lesion that's not too large, never been attempted, no tattoo at the lesion, things like that. So, and once you start doing more of that, you can you understand, like, okay, now I didn't expect there'll be difficulty doing this step. Now you gain more experience and you can start doing the procedure on the more difficult lesions. And during this time when we start this service, you may not have a lot of referral, but it's important for you to continue training at least 2 to 3 ESD a month. So if you don't have referral during that time, I recommend that you should continue doing the animal training to keep up your skills until you have like every week. Then you don't need to. I don't think you need to go to the animal lab to do ESD in the pig stomach anymore. So I stop here. I don't know, anyone have other thoughts or any comments?
But, you know, I think I agree with Sawani. A lot of us, you know, we all work at these big tertiary referral centers. So ESD has to be part of our kind of cancer care. And I'm fortunate my surgeons and oncologists at my hospital are well aware of the technique. You know, the surgeons are more than willing to let me give it a try to see if the patient is an endoscopic candidate and save them an invasive surgery. And, you know, as far as costs go, though, with interventional endoscopy, you're right, this procedure often does take a long time, but the actual knives are not that expensive compared to, you know, a lumen-opposing metal stent or things like that. But, you know, so in that respect, I feel like you can get the devices, but the training is key, not only for yourself, but the staff, and also just having realistic expectations. You know, I can't book an ESD for half an hour. It's just not going to happen. So you have to make sure that you allot yourself enough time. And I'm just very picky about which cases I select. Some things I just know that it's not in my skill set to take out a 20-centimeter lesion in the you know, angularis and half the stomach. But, you know, lesions that I think I can do in a reasonable amount of time that would be, you know, similar to maybe a surgery. But if the surgery is going to take less time than my ESD, then you know, you got to consider that as well. And as far as training, and this kind of goes into my talk about hybrid ESD, for a lot of people, if there's at least getting familiar with ESD techniques, obviously you do courses, if you can do animal training. Sawani and I spent time in Tokyo at the National Cancer Center observing cases, but hybrid ESD is a nice way to kind of ease your way into getting to a complete ESD, where you at least learn how to use a cutting knife. You learn how to do, you know, identify the submucosal plane, deal with bleeding vessels, and then, you know, you can revert to a snare at the end to save a little bit of time and just get the lesion still done in an en bloc fashion. But it just gives you more options. ESD, doing the actual complete resection is not the end all be all. Just having the ability to know how to use cutting knives for different indications, I think that's, you know, a worthwhile skill for interventional endoscopists to have.
Oh, well, thank you so much for both of you for that. Sawani, we all face, well, you face a lot more difficult lesions than most of us. But what do you do when you see that the lesion you think is going to be difficult? First of all, what are the difficult lesions? What is your plan of action for those? Do you retract? How do you do it? And ultimately, if we're faced with incomplete resection, what do we do after?
Thank you. So let me digest the questions. So the first question is when we encounter difficult lesions, what do we do? So it depends on what difficulty we expect. We think we're gonna encounter. So if it's in the colon, for example, and I know I'm gonna take a long time, I prefer to use the overtube system to help stabilize the scope control. Otherwise, after you spend half an hour, the colon become dilated, and you may have a problem with looping. If the problem is fibrosis, like prior attempt, so I already think in plan ahead of time. Okay, I'm gonna have low threshold to use couple of devices that will help me. For example, ST Hood, the hook knife, or change to water pressure method. So these are like if we do ERCP and we have the algorithm that, if we cannot cannulate, we're gonna do pre-cut, and if pre-cut doesn't work, so we have that in ESD too. So that's, but we like the to predict the difficulty, we have couple of risk factors: size, location, submucosal fibrosis. These are the three major risk factors for difficulty. So it depends on what kind of difficulty we encounter. So if the resection result in non-curative resection, it depends on what that is. Non-curative resection from piecemeal resection during the procedure, because we could not complete en bloc, the risk of recurrence almost similar to piecemeal EMR. So if it's benign lesion, then you have to follow them like you do EMR. So if it's en bloc resection, but pathology read margin positive, then we have to, the next question is vertical margin or horizontal margin. Because if it's horizontal margins, the risk of recurrence is still really low. Particularly if it's non-malignant lesion, risk of recurrence almost similar to R0 resection, based on a new study that we discussed in the lecture. But if it's vertical margin positive, which means cancerous lesion, this is still conflicting data whether we should recommend surgery. Right now, still need to recommend additional therapy. Although we know there are more and more data show that if it's only positive, like for the colorectal lesion, the invasion more than 1,000 micron and no other risk factors. So those might have very low risk of lymph node metastasis. That's based on the Western data, but the long-term follow-up data from Japan show that the recurrence is still almost 10% of cancer metastasis for those with the long-term follow-up data. So at this point, still recommend surgery for vertical margin cancer positive, even without no other risk factors.
That was great. So Wani, I'm gonna have you rest and go to Maria Jose. I actually want to show, yeah. So this is just, we haven't done anything for this yet. And the referring physician said it was just a little bit irregular. And they actually, that person wasn't sure if it was anything there. And was a bit surprised that it came back as tubular adenoma. The question is, they didn't do anything to it except they took a lot of biopsies, and then it came back as tubular adenoma. Maria Jose, what do you think I should do with this? And the question is, at what lesion do we not consider performing EMR, or would you still proceed?
So I think everybody that does EMR, it's crucial to know polyp recognition patterns. More than size itself, it's very important to understand which lesions can we remove when we're going to start an EMR. And then taking time to evaluate a lesion, regardless of the size, I think it's one of the most important steps along to have an idea of the plan that you're going to use for resection. So on this lesion, I will be concerned a little bit in the middle. It looks like compared to the rest of the margins, it's a little bit more depressed.
Right.
And it looks more flat, right?
Yep.
So the lesions that I will not resect are those that have a central depression, or when I look into NBI, if I'm concerned of invasive carcinoma. Those lesions are usually deeper, and the approach for a malignant polyp will not be EMR. It will be actually surgery, tattooing the lesion and go for surgery. Now, if that lesion was biopsied, I would be curious to see if the biopsy was done at the periphery, which does not seem to be depressed, versus in the middle, because then the slight changes that I see in the middle could be from fibrosis. If you're not 100% convinced, another thing that I think is very helpful is when you attempt to resect a lesion and it's not lifting, that gives you an idea of deeper invasion. And again, I would not resect the lesion. But again, when the more EMRs you do, and then I think this is also very important for training with any type of resection in the upper or lower GI, recognition of the lesion for just adenoma versus high grade versus invasive cancer it's crucial.
Let's say if we're lucky, and it's actually not a very, or at least we don't know, because I don't know what the true margins of the lesions are at this point,
Mhm.
because we haven't lifted and we haven't sort of highlighted it. But let's say if it's a relatively small lesion and we're lucky and it lifts, and we took it out, let's say in 2 pieces. What adjunctive methods would you do after the EMR? Do you do, what kind of thermal ablation on the margins would you do, or how you would do it?
So let's say we remove a lesion. If ideally, some lesions can be removed in block, but a lot of times we get polyps that are 20, 30 millimeters that require piecemeal resection. The most important thing is, I think, when you resect these polyps to reduce the recurrence, chances of recurrence, is not to leave islands in the base. But the other thing that we add towards the end of the resection is ablation of the margins. It is important to make sure that you don't leave any adenomatous appearing mucosa when you ablate. So what we want to ablate are the margins, but not, if possible, do not ablate what you think it's still adenomatous lesions. Those should be resected. But to reduce the chances of ablation, again, sorry, for recurrence, it will be to ablate either using, some people will use APC, some other will use the tip of the snare. I don't think there's like studies comparing side by side, but we know that both techniques, either one you choose, reduces the chances of recurrence. And then the other thing very important is whenever you do an EMR of a polyp, let's say this did not come in one piece, follow-up is really important. So all the patients that come for a EMR, they should know that part of the procedure is not only taking the polyp out, but follow-up in 6 months. It's really important to make sure that these patients did not have any residual or recurrence of that lesion. So it's very important that the patients are aware of, like pre and post-procedure expectations. So they know that if you're able to remove the polyp, they need a close follow-up.
That are the great points, and also a great segue to all the questions that I'm going to ask Uzma now.
I know. I was just I agree with everything that was just said, though. And sometimes that injection definitely with dye helps you define the borders a little bit better, whether it lifts or not. But oh no, this lesion.
That is all for you. That is all for you, my friend.
Okay, where are we? Where is it?
We're in the rectum. We are about 2 centimeters above anal verge.
Okay, I mean, this lesion doesn't look that big on first glance, but under NBI, some of those pit patterns look irregular.
Oh, sorry. Yeah.
Oh, I would rather do the next one, but.
Sorry, next one is not for you.
But the pit patterns do look irregular. It is a little bit depressed there in the center. And, I think for the audience, there's so many classification systems that sometimes it's hard to remember, but you can kind of just generally gaze at this lesion when you look at it and say, okay, these pit patterns look definitely abnormal, increased vascularity, and it's a little bit depressed. So perhaps there could be some level of possibility of malignancy in here. But, I would still try to lift it. And then, because it's the rectum and it is on the smaller side, I tend to, and I have moved a little bit more towards trying to do ESD or get an en bloc resection. So whether that's with ESD or with a snare, I think if you can get it out in one piece, that would be ideal so that you have good margins on this lesion. Because I've had colleagues where they just take out rectal polyps in a piecemeal fashion that may look like this, then you get a positive margin, and then everyone's stressed what to do. But this might be a good place to test out a hybrid ESD. You can make or we have this technique, which is a form of hybrid ESD that was my colleague Waxman developed at UChicago, which we use, called DSCAR, where you kind of dissect all the way around the lesion. You create a moat for your snare to sit into, and then it's easier to get it off in one piece. But you have a lot of options for this lesion. But I think it could.
Yeah, no, go ahead. The reason that I showed it and the reason why I remember this case is because it was my first not so good ESD case from about a year and a half or two ago. And so we did what you said. So we dissected, and it took so long to get to.
It was fibrosed.
It was fibrosed in the middle. It was underneath that thing. It took so long that we finished with the snare, and I always felt it came as a benign polyp, and the patient had no recurrence since then.
In rectum,
that is the reason that I wanted to ask you about that.
Rectum, you can get a lot of fibrosis, even if it is a benign polyp. But 100%, I still stand by this lesion. I would want to get off in one piece, because you'd rather have that negative the benign pathology at the end versus a potentially positive margin.
Now the question is, how much, when you do the hybrid, how much do you have to dissect to you think that is the right thing? How much would you go? Most of it?
I mean, if you can get at least half, you just want to be able to put your snare around the lesion, and oftentimes depends on how big of a snare you're willing to use. I typically don't use snares bigger than 2 centimeters in most cases, but sometimes if it is a big lesion, I might go to the 3 centimeter snare, knowing that the base is much smaller. And I'm going, I've already dissected enough to where I know I'm getting the entire lesion in one piece. So it does depend a little bit on the lesion, but you might say you're going to dissect to the point where you don't need traction. And if you need traction, then to complete the ESD, you might think, okay, I've dissected at least halfway. I can get my snare around the base, and I'm just going to go for it with a snare. But the more you can dissect, the more chance that you're going to have a negative margin, because sometimes if you go too soon and you put a snare around it, you're going to leave a little bit behind on the base.
Yeah,
so it's a little bit subjective.
I see. But what if you encounter, like we did, fibrosis in the middle? Would you still get a snare at that point, or you think this is a sign to dissect? And please, everybody chime in too.
Again, I think it depends. How much fibrosis? Am I getting any lift at all? Do I think that adding a traction device would help get me through that? Is it just a small area where I think, okay, we'll just put a snare and we'll get through it? A lot of it just depends, I think, on how much fibrosis and how big the lesion is.
Anybody?
Yeah, I might put on the point that if we encounter with the fibrosis, beyond that point that Uzma have raised, I think it's about the scope, maneuverability. If the scope is stable enough and I can get into the submucosal space, if I can create the tension and I can use some device, for example, like the scissor type knife, that would be okay to dissect the fibrotic area with continuing with the ESD. But if the scope is unstable, I cannot find a good submucosal space, and the tissue cannot be dissected with the available knife, then I go with the hybrid ESD.
And sometimes I brought up factors related to the polyp. Sometimes it's factors related to the endoscopist. So
thank you for that, Uzma. There were a lot of factors related to the endoscopist at that point.
If it's been 3 hours, and I mean, things are not necessarily progressing with the ESD, you need to finish the procedure, obviously in a safe fashion. So if you have to resort to a snare, then so be it. But that case also highlights that we're not always so accurate, again, with our endoscopic diagnoses, especially in the rectum, especially after something's been biopsied or previously resected. And we probably do overcall a lot of lesions, but there's also a difference sometimes between what a biopsy says and what the unblocked resection will say. So the biopsy may suggest intramucosal cancer, can't rule out invasive component, and then you resect the whole lesion and it's just a villus adenoma. So again, the en bloc resection helps in that respect too, even if it's just a downstage.
Yeah, we have a bunch of questions for you. So the first thing that I'm gonna start with is that we gave you the hardest topic of everybody. We gave you a topic of all the challenges, or we call it complications, that happen with tissue resection. So when you're faced with the lesions, maybe like this or worse than that, and we frequently encounter patients on antiplatelet agents, on anticoagulation, how do we approach it? How do we manage this?
Yeah,
So-
for antiplatelet, I think it's not a big problem, especially with the aspirin. But for anticoagulant, is had a very higher risk of the post ESD or post EMR bleeding, especially if the patient on DOAC is give the higher risk of delay bleeding if we resume the DOAC quite soon, early after the procedure. So for this lesion, where is it? It's on the.
It's actually like literally just very distal, maybe a centimeter or two from ileocecal valve. Right colon.
So is this electrofraction view? And
Yes.
so you mean if I will resect this lesion during the patient on anticoagulant or antiplatelet?
Yeah, both actually. I'm
So
gonna make it difficult for you. Come on.
In the US, everybody's on multiple agents.
Everybody is on everything, right?
Yeah, I think this one look a granular lateral spreading tumor, and it should be not contain the submucosal invasive cancer, so it can be resected with the EMR. But if the patient on dual or multiple antithrombotic agent, I will postpone the procedure and I stop the medication before repeat the EMR again.
Is that pretty much everybody is gonna do the same?
Yeah, I will add also, if the lesion is, some studies have shown the benefit of clipping these lesions, especially in the left colon, when they're like bigger than 20 millimeters, those have higher risk of have delayed bleeding compared to the lesions in the, in the right colon, they have more chances of bleeding compared to the left colon. So if this patient is going home on Plavix or Eliquis or aspirin or warfarin or a combination of those, I will definitely clip and still tell them, there's still a but smaller risk of delayed bleeding that can occur up to 2 weeks. But again, larger lesions in the right colon, I would clip as well.
I was gonna say now, also, I've mainly for SSPs, but this one's kind of a flat lesion. We all agree it's benign, considered cold snaring, right? That's been gaining more popularity. And again, you still just try to make sure you're not leaving any behind, but that's another option to try to prevent delayed bleeding. And just one note, in our office, I never stop the blood thinners. We need a note from whoever is prescribing that blood thinner. It needs to say it's okay to hold, however many days before, and then if possible, 2 days after.
Oh, thank you so much for that. That is a great point. And that's actually what we did pretty much, and resected it. Now, we did it cold.
Cold, okay, yeah.
Yeah. So if we did this cold with a large margin, would you guys do the thermal ablation around or not? Yeah.
I would say yes still. Oh, but then it always becomes a question. You have to bring out a new snare to do that.
Yes.
Yeah. So but that sometimes does come into play.
What about the option of just cold snaring a little broader around the margin?
Yeah, we did big margin. Do you have to do a big margin? Yeah, would you still thermal ablation, Maria Jose? Savani would be as deeded
I
in
wanna
5
change-
minutes.
I'll
and-
change my answer to no, because you did the wide margin, so,
I did, I swear, yes.
yes.
What do you guys, Maria Jose, Yaporn, what do you guys think?
I won't put the thermal abrasion.
Okay,
Yeah,
how about my
if you're sure that you did like wide margins, I wouldn't,
promise
because that will be your, you know, your non-thermal
on me?
ablation, you know, but yeah, I would just.
Right.
Then did you clip it or not?
Well, just 1 second
Oh,
before
sorry.
it's on the next slide. Come on. So actually, I want to bring up Yaporn. You had a great review. You guys should read it on the difficult lesions for tissue resection. And I wanted to ask you about anal lesions, how you approach that before we go to the last question of the day.
For anal lesion, there's some problem with the endoscopic resection. For example, like if the patient present with hemorrhoid, there are a lot of blood vessel there, and you can encounter with the bleeding during the procedure, and this might compromise your speed of dissection. And the second one is about the stability of the scope. If the lesion is on the anal canal, it's quite narrow area and the scope cannot be holding in the stable position. So usually I will do it with some special device. For example, if we can use the knife with hemostatic property, like the scissor type knife, so we can hemostasis first and then we cut the vascular area. That is one point. And another one point, we can do the lateral flexion scope in the lateral flexion area, so it might stay more stable when the scope is doing in the retroflective position. More than that, I will put lidocaine during the submucosal injection to reduce the post-ESD anal pain. That at some point that I pick up from the anal lesion.
So now we come to the last question, last slide. We're closing this, like Maria Jose said, I have to close the closing. And we chose X-Tack to close with. And my question to you guys, sometimes it looks beautiful, right? It's like one system, this whole business came together, it was nice. But do you guys feel that this is more like we're creating a tent on top of the resection mark? I feel that I'm worried about that. And the patient is going to be on antiplatelet and, coagulation, anticoagulation agent. Do we just kind of cover it or do we actually close with these new devices? That's the question. And which you prefer?
I have few experience with the X-Tack, and I can feel that there are some still a dead space below the mucosa. So the lesion was caused only on the mucosal surface, but underneath it is still there, the dead space. So I don't think it quite works. Usually I prefer to use the hemocrypt to cross the mucosal defect. Even not the whole area, but some area that I feel like the deepest area or the area with the deep injury. So maybe you can share your experience with the X-Tack, because I have only...
Yes. So yeah, I agree. Most people would say X-Tack is tissue approximation, not closure, because with the technique, we put each tag about 5-10 millimeter away. So it's like you pull tissue around to cover. However, from the data we know, the risk of delayed bleeding is still very low. Like the data that we published in X-Tack for colorectal ESD, there was about 90 patients. There was no delayed bleeding. I know risk of delayed bleeding is not that high in colorectal ESD compared with EMR, but still there's a signal that is decreased delayed bleeding. Another possible explanation is that even though we cover it, but it's like mechanical completion at that area. and also prevent fluid or GI content to irritate the area. That might also explain that it might decrease delay bleeding. Still, we need more data on this device compared with clips.
I want to be mindful of our time and not keep you guys too long, but Maria Jose, is it the clips or X-Tack for you?
You know, I don't have a lot of personally use the X-Tack for closure. I typically go for the clips. If it's a large, I'm use like the bigger clips such as the Mantis to approximate like in the middle and then close the rest with regular clips. But that's my personal experience.
Uzma, what about you?
I agree with everything said about X-Tack. It depends on the lesion, and a lot of times you're just superficially getting that mucosa. So I try clips, but the reality is some of these really big resection sites, I'm not going to close. So now I think we have to look at the data and see where maybe these hemostatic powders or gels, maybe those would be something that would help us in the future. But I just warn the patients, listen, this is huge. We're going to get it out. Here's my number in case you bleed.
That's a perfect way to end. I actually just want to put a little plug, Uzma, for that was a great piece you had in GIE on the tips for EMR. I love it. You said, when in doubt, refer out.
Yes.
Right? That
Always.
that was the one. Always.
No pride in endoscopy, right? So
we're so grateful to all of you to spend time with us. I know we ran over a little bit, but it was a great discussion and we appreciate all of you.